So, hello everyone, welcome to this start of a new cycle of webinars on bioethics. We are with the students of Cal State University. It's really my pleasure to start this new cycle with the Professor Jacob Appel. Sorry if my pronunciation is wrong again.
Good.
Today we are going to discuss rationing versus squandering and how to find an ethical balance in healthcare expenditures. I hope you enjoy this webinar and the floor is all yours, Jacob.
Thank you. So basically what I want to talk about today is how we spend our money in healthcare. And you'll often hear people say we spend too much money on healthcare, and then people say, but we don't have enough money for me to get the healthcare I need. So I want us to think about less about how much we spend overall, though we'll talk about that in a minute, and more how we spend it in the healthcare system. So there are three different kinds of scarcities or shortages in healthcare. There are hard scarcities. Those are things that no matter what we do in the short run, we can't make more of. So organ transplant is a very concrete example. Although there are systematic changes we could make to make more organs available, there's no way we could get more organs tomorrow short of going out and hunting down strangers and taking their organs without their permission, which I imagine none of you would think a good plan. Pediatric neurosurgeons, another example. Obviously, we could train specialists in the field over many, many years. You wouldn't want to have a one-week seminar online to train a pediatric neurosurgeon. Secondly, there are things which are soft scarcities, which means we've set up a system where there's a shortage, but we can fairly quickly change it. And healthcare dollars are a really good example. Tomorrow, the government could decide to allocate more money for healthcare, and we'd have more money to spend. And third, there are what we call evaporating or conservable resources. And these are things we may seem to have an unlimited amount of until we misuse them. Some of you may think globally the planet may be a good example of that in a different sphere. But here, antibiotics are the classic example. Antibiotics are very efficacious against bacterial disease, but if we use them too often, let's say treating viral sore throats with them or giving them to animals to fatten them for market, then eventually they will lose their efficacy. I want you to think back to non-crisis times. I know it's hard to imagine someday you will tell your children what a concert was or what a restaurant was. And in non-crisis times, and today still, there are three different kinds of allocation in the healthcare system. First, there's macro allocation, and that's basically the amount of money our society spends on healthcare versus not healthcare. So right now we spend about 18% of our gross national product, or 18% of all of our economy on healthcare, which is a lot compared to, let's say, 6% in education. And you have a chart on the right which shows you how much money other countries spend. What I want to emphasize, though, is how much money you spend on healthcare during non-crisis times impacts how much money you have to spend in healthcare during crisis times. So, for example, if we had a healthier population at baseline, if we spent more money on preventive care, we would have to spend less money now on care for patients with COVID because patients wouldn't get as sick. One of the reasons our society spends so much money in healthcare was outlined by an economist named Lester Thoreau, who says that Americans at their core are both egalitarian and libertarian. Those are fancy words. What does that mean? That means that on the one hand, if there's some very wealthy person out there, like Bill Gates or Warren Buffett, who can afford a particular medical treatment, we don't feel comfortable saying, if you can afford it, we're not going to let you have it. Some European countries do that. That's why some of their citizens who are wealthy come here for care. On the other hand, once we say that some wealthy person out there is allowed to have it, we then feel guilty, and we as a society feel that everyone should have it, but since they can't afford it, the taxpayers pay for it. And in that sense, a rising tide raises all boats. I also want to introduce you to a man named William Hammett Davis, who I would suggest to you is the most important man in the history of American medicine, and he was not a doctor, and most people have never heard of him. Instead, he was the head of the War Financing Board during World War II, the War Production Board. And during World War II in the United States, there were price and wage controls to control inflation, which meant that businesses couldn't raise prices, and they also couldn't raise salaries of workers. So the question arose, how do you attract workers if you can't pay them more? And the answer was some companies, most famously the automobile companies, started offering really good fringe benefits. and really good healthcare plans. And the question that Mr. Davis had to answer was, do these increased benefits count as wages, and therefore they can't be raised, or can private companies offer an unlimited amount of benefits? And he decided these were not wages, and companies could offer an unlimited amount of benefits. And the result were what were known as Cadillac healthcare plans, because the largest car company, General Motors, most expensive car was the Cadillac. These plans, which were largely tax exempt, existed until the Affordable Care Act, and by the early 1980s, played such a large role in the American economy that General Motors had become a large health insurance company for its retired employees that also happened to manufacture automobiles. Second kind of allocation is meso-allocation. That's where within the healthcare system we spend our money. We could spend it on research, on prevention, on acute care, but it's worth remembering that the more money we spend on research and prevention in non-crisis times, the less money we have to spend in acute care in crisis times. You all may remember the Ice Bucket Challenge. That was the effort in the United States to raise money for Lou Gehrig's disease by people pouring buckets of water over their head, and the president did it, and the former president did it. It raised about $100 million. That seems like a lot of money to you or me, but to give you context in how small a percentage of our resources that is, that's half the amount of money Americans spent that same year on Halloween costumes for their pets. For their pets, think about that. And third, there's micro-allocation of dollars. That's what individual disease and demographic groups we spend money on. So a couple of examples. You will look at that chart, and things on the upper left have more money spent on them than the number of patients suffering them or the number of lives saved. And things in the bottom right are underfunded. Historically, AIDS, HIV, breast cancer were underfunded, but there's been a major shift over the last 20 years. Now the things that are most underfunded are mental illness and large-scale preparedness, like pandemic preparedness. And I used to go around the country showing this slide before the pandemic, and people laughed at me and said this wasn't that important, and this should give us pause. I want to give you one particular example of how particular ethnic and racial groups can be disadvantaged by the system. So I want to compare two diseases. One is cystic fibrosis, that is a disease both more common in white Northern European and people of white Northern European descent, and perceived to be a disease that affects that group. And the second is sickle cell disease, which is more common in African Americans, but more importantly is perceived, though not exclusively, to be a disease of African Americans. I also want to emphasize that sickle cell disease is far more common than cystic fibrosis. In spite of that, the National Institute of Health spends more money per person on cystic fibrosis than on sickle cell disease. Private philanthropists spend more money donating to cystic fibrosis versus sickle cell disease. Over the last decade, substantially more papers have been published on cystic fibrosis. More clinical trials have been conducted, and this really gives you a sense of bias in how we allocate resources. So I mentioned that $100 million was spent in ALS research, $200 million on Halloween costumes for pets, only $76 million for sickle cell disease research. We as a society often talk about providing healthcare for all. And I would suggest to you, for most people, that's an easy decision. The hard decision is figuring out what constitutes healthcare, what goods and services we put in that basket, and is there a limit on how much healthcare we offer people? So, for example, if I were to ask you for an iconic example of something that is healthcare, most people would say that removing a malignant carcinoma of the breast, removing breast cancer, is healthcare. What about surgically restoring that breast with cosmetic or medical surgery to make the breast whole again so that the woman who has suffered from breast cancer feels whole? Is that a cosmetic procedure or a medical procedure? Well, for many years, that in the United States was viewed by the healthcare system as cosmetic. Now that is largely viewed by the government and by insurance companies by law as medical. What about top surgery for transgender patients? Up until fairly recently, that was considered a cosmetic intervention. Now, increasingly, a number of states view it as a medical intervention. In contrast, I want you to look at the man on the left. That is male pattern baldness. Some of you view that as a cosmetic intervention, and there tends to be a gender breakdown on this. Some of you view this as a severe medical condition. As you get older, more and more of you of the male persuasion will view this as a severe medical condition. I can tell you from personal experience. We spend $2 billion a year trying to cure male pattern baldness. versus 76 million for sickle cell disease. That should really give us pause. I want to tell you a little bit about Slim Watson. Slim Watson was a prison guard in North Carolina. And in 1999, he noticed these blotches under his skin on his arms that were little hematomas. He was bleeding under his skin. And fortunately for him, unfortunately for them, his local hospital was the Duke University Medical Center, one of the best medical centers in the country. And they diagnosed him with a very rare condition known as factor VII inhibitor syndrome, which even if you go to medical school, you are unlikely ever to see. There are only a couple of hundred cases in the history of the world. But for your purposes, it's very similar to hemophilia. It's a disease where you have uncontrolled bleeding. Unlike many of the famous cases in bioethics, where patients are in a coma or incapacitated, like Karen Ann Quinlan or Terry Schiavo, Slim was bright and cheerful, able to wander around the hospital. They got him a gig entertaining patients in the pediatric units. The only thing he couldn't do was leave the hospital, because at first he needed a medication that cost $1,000 a vial that you got every hour on the hour. And it was harvested from pigs on a farm outside of Birmingham in England. And then in 2000, a rare swine virus knocked out the pig population. And there was only one experimental treatment left, called Nova 7, which is now in the market. And at the time, it cost $12,000 a vial, and you needed a vial of the medication every hour on the hour, and it was perishable. So an entire industry sprung up around Mr. Watson, where planes would fly from Copenhagen in Denmark to Raleigh-Durham in North Carolina, and he would get this medication transfused, and much to the hospital's frustration, he neither got better nor worse. And his hospital bill at the end of the first month, his wife was relieved to learn, was only $300,000. Why? Because Duke's computer system couldn't print the digit to the left. His first hospital bill for 1 month was actually $5,300,000. Duke was so concerned, they went to Congress, telling Congress that in 2 years he would bankrupt their hospital system, to pass the Slim Watson Act, which would provide Medicaid coverage just for Slim Watson alone. You should ask yourself, at what point do you cut Slim off? Do you give him 2 years worth of health care at what they estimated would be $120 million? That's more than the Ice Bucket Challenge realized. Fortunately for them, unfortunately for him, he died about a month into his hospitalization. But one of the reasons we know about his case is because of that. There are a number of other cases in our healthcare system which we don't know the details of because the patients remain alive, still using this level of resources. Is there a point where you receive too much healthcare? We often hear that money spent at the end of life is a large percentage of healthcare dollars. So for example, that 30% of all Medicare expenditures are attributed to the last 5% of beneficiaries that die within a year, and 1/3 of all healthcare costs occur in the last month of life. That seems like useful information, but I would suggest to you it's actually not very useful. Why is it not very useful? All of you who are in the last 6 months of life, raise your hands now. You see my point. So you only know when you're in the last 6 months of life often when you're in the last 6 months of life. Hindsight is 20/20. In the United States, we have an expression called Monday morning quarterbacking. On Monday morning, it is very easy to say what the football captain should have done while calling the game on Sunday afternoon. So if you are diagnosed with ALS, the disease for which the Ice Bucket Challenge was raised, which is generally fatal in 3 to 5 years at most, historically, if you type the words ALS or its other name, motor neuron disease, into the internet, and you type the word prognosis, what came up? The first thing that came up was a picture of this man, Stephen Hawking, the British physicist who lived 40 years. Just another example, if you type abdominal mesothelioma, a disease that has a 2-year life expectancy and prognosis into the internet, you got a picture of this man, the anthropologist, biologist Stephen Jay Gould, who was nominated for Pulitzer Prizes and National Book Awards and lived 20 years after his diagnosis. Why do I mention all this? Because only a handful of people may survive this long, but everybody wants to have hope, and everybody thinks they're the tail. So nobody feels comfortable cutting off dollars in a rational way, even if they know that overall, in the long run, more lives will be saved. So these, in 2013, were the world's most expensive drugs, and those seem pretty expensive. I am a physician. I will tell you I have ordered none of them ever for a patient. I imagine if I ever order one of them for a patient, I will get a lot of pushback from the hospital. They are child's play now. As of last year, Zolgensma has entered the market. Zolgensma is a medication from Novartis for spinal muscular atrophy, a debilitating and often fatal disease of young children that costs $2.1 million per dose. There are about 6,000 children with this disease. That is not a typo. The pharmaceutical company is making some profit off that, but even if you just factor in the margins for what it costs to research and manufacture the drug, you're still talking about over $1 million a dose. So the question is, who should get coverage? Should the government provide care? Zolgensma, Novartis, when they marketed Zolgensma, actually tried the worst marketing technique ever. To look like they were doing a good deed, they had a raffle for 10 doses of the medication each month. So yes, and they thought this was a good optical measure. It actually wasn't. It actually reminded the children who were dying because they didn't have the medication that they couldn't afford it. I did learn one thing out of this. As an interesting aside, I learned the difference between a lottery and a raffle. I never knew this. A raffle, by definition, has a winner, and a lottery doesn't have a winner. But they started calling it a lottery, not a raffle, because a raffle sounded far too much like a state fair or winning a pie at a church social. But it really was a raffle. I mention this because the Orphan Drug Act of 1983 encourages research on diseases that affect fewer than 200,000 Americans. And it has provisions for increased patent protection and exclusivity, tax breaks, all sorts of financial assets. Prior to 1983, there were only 38 drugs on the market in the United States that treated illnesses that affected that few people. By 2018, thanks to the Orphan Drug Act, there were 503. That sounds like really good news. Here's the problem. The problem is there are 5,000 to 8,000 other diseases that meet this criteria that are genetic in nature that will likely be treatable or curable with diseases with treatments similar to Zolgensma at similar prices. So if Zolgensma costs about $1 billion to treat the number of patients who benefit, which is the estimate, it will cost probably tens of trillions of dollars to treat all the individuals with these other diseases. And that begs the question, should we bring these treatments to market? Should we pay for them with taxpayers' dollars? Are there some people who are going to say, we can cure your illness, but it's not cost effective, we're not going to? It's a really hard thing to do. I don't have an opportunity, because this is not a fully synchronous class, to ask all of you whether or not you believe healthcare should be allocated rationally. But you should ask yourself, do you believe healthcare should be allocated rationally? Because there's been one serious effort in the United States. In Oregon, the governor in 1993 was a man named John Kitzhaber, and he was actually a former emergency room doctor. And he said, we're not spending money rationally in Oregon. We're spending a lot of money on very expensive things and not enough money on things like preventive care and basic health care for poorer people. So to tackle this problem, he decided to expand the number of people covered by Medicaid, which is the state insurance program for the poor. This is before Obamacare. And he raised it from, in its first year, 240,000 people to 360,000 people who were covered by the state insurance plan. However, the legislature did not give him any more money to spend. So he had the same amount of money, but he spread it over a larger number of people. How did he do that? He decided to cover fewer things. And he had a committee put together a list of the different things that doctors could do, of which it turns out there are 692 of them. Actually 694, because dialysis and child vaccinations are covered directly or indirectly by the federal government. And he had them ranked in order of cost effectiveness. So what were the top conditions? What are most cost effective? Treating pregnancy, delivering babies, most cost effective. You get low complications, lots of birth, lots of life years, birth of infant, preventive services for young children. Lots of types of prevention, treating tobacco dependence, obesity. Mental illness does really, really well. And then there are things that were not that cost effective. So the one I always like to mention is if you cut your finger off at this joint, they put it back on. But if you cut it back at this joint, you're out of luck. They actually figured this out down to the last detail. But it was an evolving listing. It changes every year. So in 1993, gender identity disorders were not viewed as essential diseases that paid off well. Now they are. So there's an evolution in this list. They only covered the top 492. People who were below that were out of luck. The most controversial feature of the proposal was that if you had less than a 5% chance of living 5 years with a cancer diagnosis, you did not receive therapeutic treatment. You just received palliative care, whether chemotherapy, radiation, surgery. The rationale for this was they could take the money they did not spend on you and spend it on preventive care and save many more lives. And the estimates were that by adopting this policy and spending money on things like mammograms and flu shots, they would actually save thousands and possibly tens of thousands of lives in the state of Oregon. That's a rational approach to some degree. You should ask yourself whether you're comfortable doing that. Once you answer that, I will tell you the bad news. The bad news is, and that's true, you did save thousands of lives by doing this. And there was a very unsettling optical moment where a woman received a letter from the state of Oregon which told her they would not pay for her treatment for her terminal lung cancer, but they would pay for her assisted suicide. I mentioned that that's shocking. On the other hand, she got a private charity to pay for her care, and she was dead within 6 months, so the state's numbers were right. But that's not the unsettling part. The unsettling part is a colleague of mine spoke to members of this committee off the record about 20 years ago. And we know that the cutoff number for rational care was not 5%. The reason they chose 5% was optics. They didn't feel that the public would buy a number higher than 5% over 5 years. It turns out the real number was somewhere closer to 19%. That if they told people with a 19% chance of living 5 years, they couldn't get care and spent the money on other endeavors, mammograms, flu shots, they would save more lives. And yet if you ask doctors and lay people, most of us don't feel comfortable with that approach. In essence, we don't feel comfortable with allocating healthcare rationally, which should really give us pause. I want to talk a little bit about rationing during crises in the last 5 minutes or so, because we do have a crisis now. So there have been 3 major rationing crises in the United States. The first was with iron lungs during the polio epidemics of the 1940s and 1950s. And the way they allocated iron lungs was on a first come, first served basis, which to most degree is equitable. Even though there may have been some bias in people knowing about availability of conditions in terms of race, economic background, whoever showed up, it was like numbers at a deli counter, you got the iron lung first. Incidentally, there were occasions where they made a wooden lung out of 4 plywood boards and a vacuum cleaner as a transition, and you can actually do this at home. There are videos on YouTube which will show you how, and they work. The second resource allocation challenge occurred in the United States in the early 1960s. And these were with dialysis machines. Rather than using a first come, first served basis, because they already had a whole pool of patients who needed care and they were bringing the dialysis machines to them, there was no way to do that. They excluded patients who were unlikely to do well, meaning those over 45, those who had any other comorbid condition at all, and all children under 18, fearing they couldn't deal with the psychological consequences of dialysis. And they still had hundreds of patients needing this life-saving care and only 4 slots for them. So they ran a process similar to a college application process, where people sent in applications and they reviewed the charts and they made determinations based on social worth, hence the term the God Committee. They had so little sense they were doing something objectionable, they had Life magazine come, and Life magazine sat in on their meetings and then printed the transcripts. And I will actually share with you one of the transcripts to give you a sense of what this was like. So a housewife on the committee said, if we are still looking for the men with the highest potential of service to society, then I think we must consider the chemist and the accountant have the finest educational backgrounds of all 5 candidates. And the lawyer said, both of these men made provisions so their deaths will not force their families to become a burden on society. And the state official, but that would seem to be placing a penalty on the very people who've been most provident. And the surgeon, how do the rest of you feel about number 3, the small businessman with 3 children? I'm impressed that his doctor took special pains to mention that this man is active in church work. This is an indication to me of character and moral strength. And the lawyer, it would also help him endure a lingering death. And the minister, perhaps one man is more active in church work than the other because he belongs to a more active church. And finally, the labor leader. For the children's sake, we've got to reckon with the surviving parent's opportunity to remarry. And a woman with 3 children has a better chance to find a new husband than a very young widow with 6 children. This should all give you a lot of pause. This is deeply unsettling. This occurred in the 1960s in the United States, leading ethicists in a committee, and they had no sense they were doing something that many of us would find deeply disturbing. I'm mentioning all that because it's the reason that we don't use social worth ever in the allocation of resources today. The third rationing crisis before COVID was one of what to do if there were a pandemic, sort of like this of swine flu or some other respiratory disease in which there was a shortage of ventilators. There are 2 sets of ventilators in most states. One are in hospitals, and the other in long-term care facilities. And the ethical dilemma was whether, if patients coming to the hospital would need ventilators for a short period of time, they could be, and then would be discharged from the hospital to recover and use the ventilator again, the state could commandeer the ventilators in the nursing homes and long-term care facilities to use in acute care, in essence, killing long-term care patients to save more lives. And a number of states grappled with this. New York State decided that states could not do that. Some other states did not make a firm decision. I mention all that because this relates to COVID. And a couple of the questions that came up during the current pandemic are, let us say a patient shows up at the hospital now with a C3, C4 spinal fracture. So they're a patient who is never going to regain the ability to breathe on their own again. They're paralyzed for life. In ordinary times, we would guarantee that person a place in the ventilator. Someone like Christopher Reeve, the actor who played Superman. But if we know that same ventilator can be used over and over again to save multiple lives during a pandemic, is it the right thing or the wrong thing to give that ventilator to one person who will take the ventilator out of the pool? A second dilemma we faced was whether or not life-saving liver transplant should be performed during the pandemic, because these are patients who without a liver will die, but we also know that they're vulnerable to COVID and immunocompromised. Their life expectancy is often shorter, their mortality rate is high, and most importantly, the average liver patient, transplant patient, takes a ventilator out of the ventilator pool for 11 days. And the third dilemma was how to redeploy resources. So for example, if we have an ophthalmology clinic here that screens patients with genetic orders likely to induce blindness, can we shut down the clinic and use those ophthalmologists, which some hospitals did, for ICU care or emergency medical care during the pandemic, in essence, trading off some patients' lives for other patients' vision? And then what system do we use for allocating a defined scarce resource like ventilators? And there are different systems we could use. We could use short-term prognosis, whether you're going to recover from this particular disease. We could use life expectancy, what your long-term expectations are for longevity. We could think about your value in the pandemic itself. So should healthcare workers get some preference? Either because we want them to go back on the front lines again, which seems unlikely if they're in the condition where they need to be intubated, or maybe it's an incentive to keep more healthcare workers working during a crisis, knowing that they'll be taken care of in an emergency. And some states, most notably Virginia, actually considered saving ventilators for political leaders in case they were needed during a crisis, which I find a bit unsettling, but was seriously debated. Should pregnant women count as one patient or two for the purpose of ventilator allocation, which many of the crisis guidelines struggled with? But I think for me, the key take-home point is most current systems think they're neutral when they're really not. Meaning they think they look at every patient and say, what are your comorbid conditions? What are your risks? And if your risk of dying is lower, we're less likely to give you a ventilator. What they don't take into account are inequities in the healthcare system that create those vulnerabilities in the first place. So if you are from a racial minority, if you have a low income background, if you live in an inner city, if you live in public housing, you may not get healthcare during ordinary times in a way that keeps you from developing type 2 diabetes or becoming obese or developing heart disease. And because you've been shortchanged that first time, when you seek a ventilator during a crisis, you get shortchanged again because your prognosis is poorer. And one of the great challenges we face is how to build equity into a system of allocation. And I think I'll stop there because that was about half an hour, and I'll take questions, thoughts, concerns from anybody.
Thank you, Jacob. This was great. Thank you so much.
My pleasure. And I will add, if people have other questions, I think it may have frozen up, but hopefully it'll unfreeze. If people have questions they want to email me, I'm glad to answer email questions too.
So on average, say it's like,
or you can just take the floor and ask the question, as you prefer.
Okay, you're unfrozen. I think somebody asked a question, but can you ask it one more time? I apologize.
so on average, how much money does the government spend on like certain vaccines, let's say?
Vaccination is a tiny part of government expenditure on medication. I don't know the exact number offhand, but it's a very, very small percentage. The vast majority of healthcare resources are spent in acute care and usually high-cost patients, meaning patients who are hospitalized either with a short crisis like a myocardial infarction or heart attack, or with long-term debilitation. Very, very small percentage of our money spent on prevention, very small percent on research.
Is there something that's changed because of COVID for the near future? So in policy or in regarding how like healthcare goes about prevention and acute care and stuff like that, has it changed because of COVID?
You would think we would learn lessons, but so far we have not, and that's rather discouraging. I will give you a very concrete way in which we have not learned lessons. So one of the suggestions during the last pandemic, the swine flu pandemic in 1999, was that all the states develop crisis guidelines for how to allocate resources in a crisis. We just actually wrote a paper on this. As of April, only 31 states had released any crisis guidelines at all, and most of them were incompatible with each other. So whether or not you get a ventilator depends more on whether you live in New York versus Kansas than how sick you are. And this may seem trivial, but there are two major problems with it. One is if you are well off, you're able to hop from hospital to hospital or from state to state until you get one that offers treatment to someone who's as sick as you are. Well, if you're low income, you can't do that. But also, if New York State allows dialysis patients, for example, patients with kidney failure, to get ventilators in a crisis the same way everybody else does, and Kansas doesn't, and there's a shortage of ventilators in New York, Kansas won't lend ventilators to New York because they know that they won't get them back to treat patients in Kansas who are sicker than those in New York. So the most logical thing, the most basic thing we could do during a pandemic beyond large healthcare changes would simply be having a national crisis standard. We have made no progress toward that over the last 5 months, none at all.
So it's not universal at all?
Not at all. It's highly determined at the state level and often at the hospital level. I think you saw that very clearly in New York, that if you got care at a high-end medical center, you did better than if you got care at a community hospital in a low-income neighborhood, which is deeply disturbing.
Yeah. Thank you.
Sure.
Hi, good morning.
Morning.
Why do you think mental health is overfunded, yet many sources of mental health aren't accessible in schools and communities?
The mental health is underfunded. I'm sorry if I misstated that. But I can tell you why mental health is underfunded. That's an easy answer. And I'm a psychiatrist, so I work in mental health. The reason mental health is underfunded is, unlike a lot of other diseases, there is not a very strong lobby, either with patients or with families, that has a lot of political power. There are very few iconic patients. People are unwilling to come forward and say I'm mentally ill, but that is starting to change. But most importantly, because the consequences of cutting money for mental health show up in the long term, not in the short term. So if you're a governor and you serve a 4-year term or you get reelected to an 8-year term, what's the easiest thing to cut in the budget? Mental health care, because the consequences will show up after you're no longer governor and they'll be blamed on somebody else. And this happened at the federal level in the 1980s and at the state level in many states during the 1990s. To give you a sense of how much was cut, in New York City, or the New York City metropolitan area, there were 22,000 long-term mental health care beds in 1980. Now there are 500. Patients didn't get any healthier.
Thank you. Yeah, that's surprising.
I mean, we all talk about deinstitutionalization, which in some ways, for some people, was a very good thing. We shouldn't lock people up against their will when they're able to live in the community. But there were also many patients who had lived many, many years in state hospitals at a level that they were very content with, matching their disease. And the state did not deinstitutionalize them for their welfare. It deinstitutionalized them to save money and basically threw them out in the street without any alternative plans for them. And I often see them in the ER now, and it's very unsettling.
Thank you.
Sure. I will tell you a disturbing story. We had a patient who lived for over 30 years in a state hospital in New York. And one day they knocked on his door without having explained anything to him in advance and told him he was discharged and gave him instructions for an outpatient appointment and wished him well. And he was a man with severe mental illness and had no way of surviving on his own, and spent probably the next 10 years going from emergency room to emergency room, trying to find a place to sleep and get food because he just could not navigate the system. Very sad.
It's shocking. Go
Sorry,
ahead.
I had a question. So saying that some programs are overfunded and underfunded, for the programs that aren't overfunded, like breast cancer, can it be their like responsibility or their choice to go ahead and help out, you know, other programs that are underfunded, or is that possible, or is that just up to their choice?
The problem is overfunded is a relative term here, not an absolute term.
Mm-hmm.
So it's not an equity issue in the sense that there still needs to be more money spent on breast cancer if we're going to cure breast cancer. So in some sense, everything is underfunded because we haven't cured these illnesses yet. It is simply in relation to the number of people suffering from the disease and the number of life years preserved. Some diseases get more money than others. So you're hard pressed to tell someone whose disease still hasn't been funded adequately enough to treat them or cure them that somebody else is better off. The analogy I could use is if you were very wealthy, there might be an ethical argument for giving money to the poor. But if you're poor, it's hard to tell people to give your food, which you have very little of, to people who have even less food than you do. And the entire system in some way is starved.
Oh, okay. Thank you.
Other thoughts?
I have a question, Jacob.
Sure.
Do you think that, I mean, education in terms of mental health, do you think that introducing a little bit of emotional education, but not through literature, you know, straightforward emotional education at school could help reducing the number of people affected with disorders, or at least could give more people skills to cope with certain disorders? Do you think that would help?
Well, I think there are two related questions. One, I think there should be more mental health education at the school level, simply to destigmatize mental illness and help people recognize mental illness early. Because there is some good data that the sooner you get people care, the better they do. So having parents who understood their children needed care would be very beneficial. There are countries that invest substantially in residential programs and emotional support at a much more intense level. Finland is the most notable one that have very good outcomes, but they're expensive and they involve a lot of community support. I'm not sure that in the way that many other things we do in the public schools here or in the school system are sort of done half-baked, that a little bit of social education would go that far. But I think if we made a real commitment, the way some Northern European countries do, we really could make a difference. I just don't see the political will to do that, unfortunately.
Yeah, I agree. I'm trying to write grants in this direction, but yeah, who knows?
I mean, it would be a wonderful thing that could happen, but living in New York City where I work in an emergency room and seeing what happens to my patients, there simply is no interest in funding mental health care right now. It is the last priority people have, which is really sad.
I had a question.
Yeah,
That's
go ahead.
okay.
Sure.
Sure, go ahead.
So I know that there are some certain research methods that aren't exactly as widely pursued due to ethical reasons, kind of like stem cell research. As of today, is there any way the healthcare budget that is impacted due to not pursuing certain types of research due to ethical reasons?
Well, I think partly the healthcare budget, such a small percentage of it is research driven as it is. And it's not clear that if we engage in unethical research, we would have very quick outcomes to cure diseases. I think one exception to that might be the debate over human challenge trials. And you may have heard about this already. So the question of whether or not we should use human challenge trials for COVID is very controversial. What are human challenge trials? Well, normally, when we want to develop a vaccine, the way we do it is we have a trial vaccine and we get a pool of people and we give it to half of them and we don't give it to the other half. The other half is the control group, and we send them out into the world and we see if they get the virus. And if the people with the vaccine don't, which takes a long time, so they need to be out there circulating, then we know the vaccine works. Another way of doing that is to actually challenge them with the virus. we take a bunch of people who are healthy and we put them in a room and we give them all the vaccine, and then we spray virus into the room and we see whether they get it. And if they don't, we know the vaccine works. And it's a very fast, efficacious way to test the vaccine. Of course, if the virus beats the vaccine, then you have a bunch of very, very sick people. And with COVID, where there's no cure as of now, you could lose lives. So that's probably the most challenging ethical dilemma that people face in research at the moment.
Oh, alrighty, thank you. That's really big. That's still hard to think about, like putting people in that type of situation.
Yeah, and the challenge also increases, like, what if people volunteer? Should you compensate people for this? Should you be able to compensate people who only are healthcare professionals because they will have a better understanding of the risk? We have done it for some diseases like dengue, like cholera, but those are to some degree treatable or to some degree manageable. Would we make sense to use populations that have a very high likelihood of surviving COVID, like teenagers or college students? Possibly, but then you don't know whether the efficacy of the vaccine in college students would apply to older people or more vulnerable people. You haven't gained that much knowledge.
Alrighty, thank you for answering my question.
Sure.
I have a question as well. May I ask? Is
Sure.
there still time for a question?
Sure.
Yeah. So hi, good afternoon from Vienna, from Austria. So thank you for your talk. I really enjoyed it. And my question is the correlation or connection between ethics and economy. So you didn't really use the neoliberal language of economy, but you said there are rational reasons, for example, to spend money on this and that. And then you asked ethical questions. But as far as so where's the connection? Did you really see, or did you mean to disconnect them and try to connect them again by asking the questions? Or is it, because as far as I understood your talk, that ethics and economy, they're just not connected at all. And this is why there are problems. And this is why it is so difficult to answer the ethical questions, because the economic calculations don't really address the ethical terms, let's say, or normativity, because ethical normativity is not really related to economic normativity, if I can say this in this way. So there is no analogy to put, actually. So I'm trying to get the way through to really answer the questions that your questions are very important, they're very urgent, as I would say as well. But do you see a way through?
Sure. So the best answer I can offer, so my goal is, you asked a very good question, is to problematize things rather than to answer them in a short lecture. But I think the take-home message is that it's not that it's not just that ethics and economics operate in separate planes, but it's that most people think that they believe in a rational allocation of resources when they really don't. They'll tell you, if you ask them a priori, and there's lots of data for this, that allocating resources in a rational manner is the ethical thing to do. But then when you give them examples, and a number of these were examples of that, where people chose to allocate resources rationally, they no longer feel comfortable doing it. And you give them examples where people allocate resources irrationally, and they tell you that's the right thing to do, whether in the Slim Watson case or the Oregon case. So my goal is simply to point out to people the disconnect, because just recognizing the disconnect is a major step forward for most people and most policymakers.
Thank you.
Sure.
We have still time if you want to ask more questions. And I'm really happy that we have an audience from all over the world. I try to advertise my webinars every week, and I'm really glad that is recruiting people.
Yeah, no, it's wonderful. I will add also, I always feel a little bit nervous because many of the things I describe are unique to the American healthcare system, and many European countries candidly do it a lot better by most standards. So take what I said with a grain of salt if you live in a country that actually has a more robust allocation system for the indigent and those in need.
there are still problems in Europe, believe me.
Oh, I believe that, but it's all relative.
Yeah, right, exactly.
I have a question. What do you suggest we do as students if we want to change the healthcare system? Like, do we need to become policymakers, or do we need to work with policymakers? Like, what can we do to change the healthcare system for the better? Because it's just run as a market, and it always makes me sad when we have these.
Sure. So I don't think it's a one-size-fits-all answer. Some of you are destined to be doctors. Some of you are destined to be policymakers. Some of you are destined to be nurses or dietitians or social workers, all of whom are essential in the healthcare system. I think the two things I tell people are, one, if you go into direct clinical care, never forget that your best day is your worst day as a provider is always better than your best day as a patient. And make sure you're putting that patient first when they're in front of you and trying to figure out what the structure is that brought them to where you are. But also, as college students, you can't change. I know it's an unpopular thing to say. You can't change the world with a capital W in that dramatic way yet. What you can do is you can interact with a lot of people who can change the world, and you can ask them really, really hard questions while they hold power, and force them and hold them accountable to answering those questions. So when speakers come and talk to you, when experts come to, or policymakers come to the University of California or online, don't let them get off with easy answers. And I know some of you were thinking that now I'm going to prepare myself for the next question, but try to push them to see the injustices of the world, because sometimes you're simply blind to them.
Right. Okay. Thank you.
Sure. And needless to say, if people do have individual questions or concerns, they should feel free to reach out to me directly.
I have a question.
Sure.
So with this whole Moderna vaccine getting postponed because there's not a lot of minority groups involved in the trial, like how does that work? How does minority have an effect with trials? And
well, I think the key question in terms of vaccination is any other works. I sit in IRB. How do you, on the one hand, guarantee that people from the non-majority group have access to research and have meaningful research done? And on the other hand, not make them victims of the research. And it's a very hard, because these are experimental treatments, and it's a very hard needle to thread. So on the one hand, we do want to have a vaccine that is efficacious across all groups of people. On the other hand, we know most likely, and I'd say overwhelmingly likely due to sociological reasons, because of baseline healthcare inequalities, that certain minority groups in the United States have much more susceptibility to COVID. We don't want to victimize those people again by overrepresenting them in trials. So striking that balance is really, really difficult, and there are no easy answers. If there weren't time sensitivity, there would be easy answers. You would start off with people from groups that are not disadvantaged, that have more access to healthcare resources, maybe more healthcare knowledge at this point, and do the trials in them first, and then expand to other more vulnerable groups to show the vaccine were efficacious in everybody, and then make it public. But since we are in a time crunch, doing that becomes even more challenging. You asked a great question to which there is no good answer.
thank you.
Other questions?
Can I ask you? I know it's 4 minutes, 5
Sure,
minutes to
sure.
end
Of
of
course.
as philosophical question. What's the criterion you use to define what is rational and irrational?
That's a really good question, because I'm bringing a very Western public health oriented answer to that question. And we either usually answer it in Western allopathic medicine with increasing the number of quality adjusted life years, or increasing life expectancy overall, reducing mortality. But those are very subjective standards. A rational allocation could take into account, on the one hand, one's value to one's family, or one's value to one's cultural group. There might be, for example, if you live in a historically traditional cultural group, some value in preserving an elder's life that transcends all other values. On the other hand, a system might take into account the injustices that individuals and groups have faced going into a particular situation and give them, I don't want to say points, but give them acknowledgement of those experiences that might make preserving their life or their welfare more valuable than other people's as some kind of compensation or some kind of equity and justice approach. So there are numerous ways of doing this, and you should not take mine without grains of salt. I use the one I use only because the Western system designs all of its data in that way. So for us to have a conversation that is data-driven, we really need to use that standard unless someone's going to do research offering us other ways of assessment, which is problematic. I deeply acknowledge that is problematic, and that's the paradox. Susie, you have frozen on me, I fear. There you go.
Yeah, I'm sorry, my connection is coming and going. Thank you. Thank you, really. This presentation was very refreshing and essential in a moment like this. I want to show you once again your book, Who Says You Are Dead, in case any of my students or the people in the audience want to know more about you. Thank you very much for the time you gave us during this presentation. It was great to meet all my students in person today. And Wednesday, there's going to be another presentation, another webinar on aging within the limits of rationality, a very interesting topic as well. And yeah, I mean, thank you, Jacob, for giving the students and everyone the opportunity to reach out to you in case they have additional questions. I think that the problems you bring up are essential. And yeah, I live in between Europe and the US, and I don't think neither of us has the answer.
Absolutely. Thank you again. Be well, everybody.
Nice day. I hope I'm not for joining this webinar.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank
Bye.
you very much.